Indeed, we've had some emotional presentations. They have been incredibly interesting, so we are over time. Therefore, I would propose to be concise because there has been a committee working since last year, working on some criteria. And again, it's an emotional topic because we are talking about people's health and lives. So can we maybe set the emotions aside and come up with some concrete solutions or steps? While I was listening to today's presentations, there are, in my opinion, two main questions. Firstly, it's actually the main topic of our conference, that how old is too old? And then financing of the medicines. So we have to start with the health insurance fund. So I would ask where or what are the age ceilings or limits based on? I wouldn't like to be quoted, so this is my reply. We'll analyze them again, revise them again. There could be different reasons, but it was mentioned on the stage today. As Allar said, we sometimes don't have the courage to say it out loud, what we do or don't do, and then lawyers get involved in the whole process. So this 3.7% of our GDP is the main reason for all of this. And then it's a question of whether we have the courage to say it out loud or not, that we don't have more capacity for medicine financing, or it can be a longer reasoning. And this is related to all these age limits and other clauses. For example, that if you start the treatment as a child, then you can continue having the treatment, but that's actually not how it's like. Everybody can ask for the floor. If you think that this age limit is out of date when it comes to approaches. Siiri, please. Yes, I asked the same question in my presentation. Why this limit of 25 years of old and then older than that? Does it work in practice? Well, I imagine that when it was drafted in the legislation, then it was just considered to be the right criteria, but we probably made a mistake. From my side, I would like to give you the state perspective. I've been in the committee for a year. Before that, I was almost on the other side of the table as a practitioner. So what can I say? Ryan talked about our GDP, our economy, that we spend 6.7% on healthcare, and the average in Europe is 8 or 9%. And I think in the States it's 15. No, it's 17, but it includes the money you have to spend on lawyers. And the minister also said that we need more funding for our healthcare. And then she added something that I didn't really comprehend. And a minister should never say it, that she doesn't know where to get that money that is lacking. And the last health minister, Peterson, also from the Social Democrat Party, now we're talking about politics, he had to analyze where we could get that additional funding. Should we change co-financing, which is high already, or raise some taxes, or different schemes that actually are available there? And the thing was that he had to analyze which was the best option. And then the government changed, and then the new minister had to come out with the analysis by the end of the year. So I would like have to ask her again about it. I can tell you that the document is ready. It got ready by December. We helped her out, but my question then is why it hasn't been shared. And we talked about 5 millions for rare diseases each year. Um, where that does money come from? And this is because we are supporting big families less. So we always talk about how worthy, how valuable our children are. We saw an incrementation in the benefits, but then afterwards it became evident that these figures that were among the highest in Europe were too much for Estonia, so they were scrapped again. So yes, there were politicians saying that they really want to support children, but it was a dirty debate indeed that I had to witness firsthand. So if we make any decisions in financing, we need resources for it. It's the same in a family. If we want to buy a new TV, we need to know where the money comes from. Are we then buying less food for our children? So this has to be taken into account in the state budget as well. What if we didn't use the age limit anymore? Well, we can make different decisions. The main thing is what our resources are. As Rain says, there's no money. The minister also said there's no money. One of the politicians once said that the money comes from the state budget, but basically it comes from the taxes that each and every one of us pays. And the question is that we have to allocate those funds so that everybody gets a little bit. So we all like to compare ourselves to the Nordic countries, but the economic situation and the population numbers are very different. So it's much more expensive to fund the state here. So we can have the aim of the Nordic states. We are working in that direction, but uh, otherwise it's difficult. I mean, obviously, nobody will say that they don't want to give money to children with rare diseases, that it's not an important topic. I'm sure that nobody would be able to say out these things that they said in our committee to a normal person on the street. So healthcare is now a political fight. This is actually quite disgusting, but I continue being a practitioner first and foremost. In my case, I'm a mother of a big family, but I don't mind these funds going to rare diseases. And this is why I also asked for the floor when we were talking about the 5 millions, because we are actually solving this problem that is before us. We are just not trying to fill in some other smaller gaps. And as I said at the end of my presentation, is that I would like the state to consider the big picture. It's not the right approach to give some money so that everybody can use them the way they want. If there is a specific issue, then if we take funding from one place and we put it in another place, then it's clear where the issue is and the funding reaches the right targets. And we have clear responsibilities as well. I totally agree. As you also said before, I would like to know, please write it to me, what's wrong with this current regulation. Now, talking about the age limit again, we don't ever have enough. That's true. But how can we improve the system? which is something we all want, because we agree that the age limit system doesn't work. So how can we make the system function better? Should it be case-based, or do we need any other approach? In my opinion, there are already some documents that the government has prepared that haven't been shared for some reason. And this is actually the plan, the strategy. The current situation is clear, so they have to make a decision. Is it 25 years, 32 years of age, or 2 years of age? So we have to look at the needs we have and then consider the different alternatives, and then we can continue working. I'm currently optimistic because, as I understood, we will see those documents soon. I would like to make a remark about those 5 millions. We are very grateful that we do have this funding that has been found, but we have to solve the issue of rare diseases as a state. We cannot depend on charity organizations to solve this issue. This is not the right way to go. We need a plan, and that plan, or those 5 millions, shouldn't mean that the health insurance fund stops working on the issue. My main worry is that when we apply for funds, we will then also bear all the responsibility. But this is not the end of the process. When we are talking about financing rare diseases, we need a state strategy. Here, I don't agree with you completely. I think that the charity organizations are a part of a healthy society when it comes to rare disease financing. We have to let the people help as well, because rare diseases are a luxury even for a wealthy company. So if there are people in Estonia willing to support the sphere, then I agree that it should be there in parallel, not as a substitute. Yes, true. I didn't mean that we should stop working. Fortunately or unfortunately, it's not possible. But we need a financial strategy, because this current 1,061 days, we are in the same league almost as Romania. Why is this figure so big? Why does it take so long? Why do we lag behind compared to all those other countries? Rain, would you like to reply? We can talk about it bilaterally if you want, Siiri, but it's a very complex issue. It's not realistic to say that we approve everything without applications. We need some kind of a system. We have tried to simplify the system, and we understand that where we have only a couple or up to 10 patients only, then it's not a priority for international companies. But we have simplified the system, and here we have to agree to disagree. When we talk about 7 pages, does it take 5 months or can it be done faster? And then 1.5 years for price negotiation. Well, we also have a representative of the pharmaceutical industries here. Maybe you would like to reply. Yes, but first I would like to say that we have already proposed a separate budget for rare diseases to finance the sphere. Of course, the question here is what are the resources? Where do we get the funding there? But if we consider the healthcare cost as an investment, because also, yes, defense spending has to be considerable as well in Estonia. But if our citizens are ill, there's nobody to defend our country. So if we spend in healthcare, be sure that the costs in other spheres will be less. So if we have a budget, we have to optimize the budget of health insurance fund. This doesn't solve the problem. What about the negotiation? Almost nobody understands how they go. I agree with Ryan here that it's time consuming to negotiate with the pharmaceutical companies. And when we have a producer in Estonia that we can negotiate with, that's a value in itself already. And the different ICER criteria that I talked about, if we cannot make considerable price reductions, then the fact is that these treatments don't reach the patients. So if the health insurance fund decides that a medicine will be reimbursed only if there's a certain price reduction, well, from the perspective of the producer, it might not be realistic. Okay, so the health insurance fund said that that's our ceiling and we cannot move from here. One example, I'm sorry, Siiri. I know that you work very well and all the donors of the 2 millions donated to the SMA type 1 of Annabelle. And with the 2 millions used to treat her in the US, it was really like a reference case. But I was sad to see that finally people said that the donors are good people and the rest of the people should just shut up. But there were some voices saying that the cost of the treatment was just too high. And this is now going to the extremes. So how expensive is too expensive? When we talk about the value of human life, you cannot put a price tag on that, right? But as a pharmaceutical company, we can then set any price to a medicine. So what is the ceiling here? We have certain figures now, certain ceilings now. I do agree, however, that they haven't been updated. They have remained the same for too long. But I know it's a bad abuse. But the thing is, you always have something more urgent to deal with. So these thresholds are set, and then you really have to have the courage to change them, to update them, because it would mean that in the future we will be in a very disadvantaged situation. Now, we know that we have a database where we paid 8 cents for our picture bank for years. But then it got outdated. That image bank got outdated, and now instead of 8 cents, the price was €2 or 1.27. Anyway, there was a lot of confusion. People didn't understand why we were raising the price tenfold of a service that was working well. But the issue was that we haven't really updated the ceilings in the sector. And in the working group, we have the same discussions. We should update the thresholds, but we are just slow in the process. Another thing that we have to discuss, the correlation of the cost benefit between the price of a medicine and the benefit for the patient. This is very painful for a family. Yes, this comes from our document. That's true. So when thinking about karma, I started analyzing what correlation means, etc. Well, yeah, do we have to define every word then? When we reply to applicants, it's the same as with putting a price tag on human life. We cannot reply that we don't have enough funds or that only 6.7% of our GDP is allocated to our healthcare. I don't want to put that in our reply. Microphone, please. You have to put it in common terms. Yes. When we talk about cost efficiency, the word in Estonian, I don't really like it at all. And we actually changed it for another word, and we put an explanation that it's evidence-based and cost-efficient. And as we heard, since April last year, the working group has been meeting. Yes, in the beginning, it was more regular. We are talking about objectives, ideals. But then when we got to the figures and thresholds, then the meetings became more and more irregular, and the meetings became shorter and shorter.
I would like to ask the same question that I asked from the Pharmaceutical Association before. Was this a conscious decision? No. Why did you leave this out? Actually, this proposal has been made many times. And when we think about this exceptional application, and maybe this question will also reach the Association of Pharmaceutical Manufacturers. My biggest dilemma today is related to a specific patient case. And if I have only one patient in Estonia, I need an orphan drug for them. And this drug has received a market license in the European Union. And the pharmaceutical company tells me that I'm not interested in filing the application. Yesterday, I even looked at the price. So it's relatively cheap. About 20 or 30,000 euros per year, which is not very expensive. And I do understand that one company doesn't want to do all this paperwork for this amount. This is an evidence proof based medicine. And I could just file an exceptional application for this drug. So I would like to ask, when will the law be amended? I have made proposals in these exceptional cases so that maybe we can discuss this case. So let's do it. I think that one or two good ideas always come up at this conference. So Siiri, we have got some things done. Yeah, to an extent. Yes, but of course, nothing goes as quickly as we would like, but things move. Last year, we spoke about how we should change things, and I understand that things are changing, and you have met and you have discussed things. Yes, this patient is also an adult, and here we also have the question of how old is too old to treat, because in a couple of years' time, there will be damaged joints, and there is no point in starting the treatment anymore. Yes, we also speak about patient-based discount, and this is one amendment that we should implement, and also a good example of why it's so important to have as many pharmaceutical manufacturers here in Estonia as possible. Because when they are far away, they might not be interested in filing the application. But on the EU level, we have a specific evaluation that will start right now for oncological medicines from 2027, also for orphan drugs. And this will take into consideration clinical effectiveness. So they will actually consider the effectiveness of a medicine. And based on this report, we can also fund medicines. And in our opinion, this should be in Estonian as well. So we don't have to file a separate application. We just have to refer to this assessment. Yes, this would make our life a lot easier because here we are speaking about ultra rare diseases. I have only maybe 1 or 2 patients with the disease. Right now, we spend a lot of time writing these 7 pages because you have to go through the medical literature, you have to prepare a chart, you have to give examples of evidence-based examples. I have a question to pharmaceutical manufacturers. In my understanding, our process is similar to other countries. In other countries, you also need to file an application. When you're a pharmaceutical company and you need to file an application, I mean, are these applications so different? If you are a pharmaceutical company and you have filed an application in Lithuania and Slovenia, couldn't you just copy-paste it partly to file it in Estonia, or are they completely different? From the manufacturer side, I can say that it would be very nice if we could just take the template, fill in the necessary information, and send it in, but this is not real life. What really happens is that the health insurance fund evaluates the effectiveness of the drug to the medicine that's currently being used. But nowadays, it's very difficult to find information that would help to compare this new drug to the old one. When the European Agency of Medicine gives its estimation, it sees whether the medicine did more good than harm. When we file our application, we have to show how it compares to the standard treatment. And then we have to explain what's the standard treatment. And they tell us that it is our task to prove that this new treatment is more effective than the old one. In some other countries, when the doctor says that there is a need, we have experience, then they don't have to prove any clinical differences. But here we have to do it. I haven't had the experience of being able to ask for the application from a Latvian or Lithuanian colleagues, although we have been speaking about that. And I have spoken about it on the European Union level. Maybe we should have a common template. I'm very happy that we will have that in 2027. When I have been writing the applications, then I have taken all the results of clinical trials, all public information that's available about the usage of this drug. I can only access the information that's been published in PubMed, and I have to go through all the articles, put this information in the chart, and show how the fact that it's evidence-based has been proven. Usually we don't have information about Estonia. In some cases, we have had some examples with the help of Children's Foundation. I hope that at the end of March, we'll have a summary of Kevin's story written by a student, and that will also describe the new ways to treat SMA. So this would give some information about our treatment results in Estonian. Marika, you showed us the proposals in your presentation. Rain, how far are you with these discussions? I think that we have come up with these criteria together. Of course, except these wonderful propositions of making 100,000 into 400,000 and 300,000 into infinity. I think I'll have to think about that. But what about next year? Will we be sitting here and will these criteria be enforced? I can't make any promises because I have the legislative power here sitting next to me. But our board is the one making decisions, so we can only make propositions to the board. And the Minister of Health, who is also the head of the board, and then goes to the government. And I don't envy Riina because she has a conflict of roles. So she is very friendly with us on the board, but in the government, she has different people. And sometimes people change mind when they go from the board to the government. When we see how much money we actually have available, that might change the decisions that we made. The problem is that when we come up with this new criterion, whatever the number may be there, we have two problems with it. The first worry is that there are some very effective drugs that don't fit these criteria. And then there's the question of solving this kind of situation. To be honest, I'm afraid that when we make new criteria and then we make exceptions that don't meet the criteria, then the exception will confirm the rule, and then there's no point in having the rule anymore. I understand the patients very well. It's a rare disease or ultra rare disease. There is only one of you. But we won't make decisions on an emotional basis. In the field of healthcare, often these preventative interventions aren't cost effective. For example, there are certain drugs or certain preventative methods that are a lot more expensive. I will give you a cruel example. Oncological treatment is very expensive. We can treat a person, we can cure them, but if we didn't cure them, they would just die. So it's a very cruel thing to say, but we can't make these decisions based on money only. And often we just have to pay as a society. I think that the rare diseases are a case where we have to pay more than maybe is cost efficient. I suppose that Capio is one of the most effective medicines for rare diseases. But what also comes to play here is the family of this child. We have heard the word struggle here a lot. The entire family is connected to the child. There are developmental issues, psychological issues, care issues. There are so many problems, and it is a big struggle. And what the families do, I think it's fantastic. I do have some patients like this in my practice who have a rare disease, and how the parents take care of their children. They are not willing to give up. It's incredible how strong these families are. And if I would just calculate and evaluate cost effectiveness, then I don't think it's actually useful for the society, but we cannot measure this in money. However, at some point, the money will be an issue. If it was up to me, I would just take the whole money in the world and I would use it to treat people. So we have to find balance here, and it's very, very, very hard. Oftentimes, in politics, we decide to take money from one people and then give it to others. Okay, I think it's time to wrap up. Have we agreed on something here today? I hope that when we come back here next year, we will have made progress. Thank you for being with us today. It was an interesting and emotional day. The 29th of February is the Rare Disease Day, so why not celebrate it? Thank you all for coming.